Good evening, everyone. My name is Krishna, and I am part of the marketing team. And first of all, I would like to thank everyone for joining us today on this important topic on newborn screening. Today, we have Dr. Sunita ma'am and Dr. Mahesh sir as a panelist. So, just to give a brief introduction, Dr. Sunita ma'am is senior consultant and professor at Institute of Medical Genetics and Genomics, Sir Gangaram Hospital, New Delhi. Her special interest lies in inborn errors of metabolism, newborn and career screening, prenatal genetics, and neurometabolism. She is also secretary of Indian Society of IEM, and she is at the editorial board of Frontiers OJRD IP publications, and she has written more than 100 articles and more than 10 books uh, on this topic. And just to give a quick intro about Dr. Mahesh sir. Mahesh sir is a senior clinical biochemist at Genome Labs, Bangalore, and he's an uh, expert in chromatography and mass spectrometric techniques. He has keen interest in inborn errors of metabolism and human metabolics. Dr. Mahesh sir has published many papers in national and international journals as well. And with this, I would request everyone to put their questions in the chat box. And after presentation, we would take them one by one. And with this, I would request Dr. Sunita ma'am to start with her session. Thank you so much, ma'am.
Yeah, sure. Thank you so much. So if I have permission, can I share my slides?
Yes, ma'am, you can.
Yeah, okay. So good evening, everyone. At the outset, I would like to thank MedGenome and Dr. Mahesh Hampe and everybody at MedGenome for giving me this opportunity. So I really, this topic is really close to my heart, so I would never tire speaking about it. So good evening, everyone. So the topic that is assigned to me is newborn screening, when, what, how. So let's kickstart the presentation for the purpose of kickstart a better life for every newborn. So newborn screening has actually been hailed as one of the top medical triumphs of the last century, where it was started. So it started about 60 years ago now with the genius finding of Professor Robert Guthrie about being able to diagnose patients of phenylketonuria based on a dried blood spot. That was a bacterial inhibition assay. And then, of course, it triggered a series of tests and modifications. And now we have more than 50 disorders that can be screened on by newborn screening. Of course, we have to follow the principles which were laid down by Vincent and Youngner in 1968. And through that, many disorders have now come into the list and are now being screened all over the world. So another very prominent change in the newborn screening strategy came around in the early 90s with the advent of the mass spectrometry, where hitherto one test, one disorder changed to one test, many disorders, which can be screened now. So we are in a very good situation in being able to diagnose so many disorders. So my outline of this talk will be centered around newborn screening, what, when, how, and of course, why. And I will be speaking about the few common genetic common disorders for which newborn screening is available, and then go on to some advanced things. So newborn screening actually improves lives. Everybody knows about it. Time and again, it has been proven beyond doubt. And this was a study by CDC, which went out and proved it. So in the USA alone, where 4 million babies are born with more than 98.5% being screened, there is screening available for up to 52 disorders. 38 of them have been recommended by the Universal Screening Program, and plus or minus here and there, depending on the states. So India, if you look at these figures, they diagnose around 11,000 babies with one or the other problem, and they are treated, and all the expected morbidities are prevented. So if we just extrapolate them to our Indian context, it will be huge. So with this introduction, we'll start. what is newborn screening, when it is done, how does it come around, what if the results are abnormal, and then what kinds of health conditions do we screen for, and what is new. So we'll just start with why. Why newborn screening? Because we really have to push this cause forward for so many years now, decades. So this is a test where which is targeted to treatable conditions. So the conditions that are being screened for are treatable. The treatment is within our reach now. It is simple and not very expensive most of the times. And there is immense data from around the world to prove that it works. So what is newborn screening? It is a public health service performed on all, it is expected to be performed on all newborns with an aim to diagnose specific conditions that can cause significant morbidity and / mortality to the baby, and for which a timely treatment would help prevent such morbidity and ultimately providing a child with a healthy, meaningful life. So a timely test allows the doctors to start the treatment before any of the harmful effects take place in the baby. So it is really more than a test. We say screening, it's not just a test, it is centered around so many things. It starts with education. So it really should start in the antenatal period where the obstetrician or the healthcare providers need to initiate the discussion, prime the families regarding this sort of test so that they are prepared by the time the baby comes in. Then the screening process itself, which is testing, followed by follow-up testing, education, evaluation, and then, of course, completing it with treating, starting to treat the child and take a long-term follow-up. So it's a full-fledged program with multiple stakeholders and with continuity. There are lots of T's involved in newborn screening, starting from technology, training, specimen taking, transportation, testing itself, that is the laboratory testing, then telling, which is reporting, tracking, teaching, continuous education, counseling, and then tracking again, and then totally. So all of these T's is what brings about this full program institute. So the recommended universal screening program in the United States states so many disorders, and I will just say a few groups. So these are the metabolic disorders which are being screened for, which include the major classic organic acidemias like the methylmalonic acidemia, propionic acidemia, glutaric acidemia, where there is overwhelming evidence that it works. Then fatty acid oxidation disorders, as simple as MCAD and carnitine uptake, where there is very simple treatment. Then amino acid disorders, endocrine disorders. There is no doubt about this fact that endocrine disorders are the most fruitful, especially in our country, primary congenital hypothyroidism and congenital adrenal hyperplasia being these. And hemoglobin disorders are also being screened for in the US, especially the sickle cell, because of the African American population where it is common. And then we come to more disorders, such as, which include metabolic disorders, such as biotinidase deficiency. In our part of the world, G6PD is very common. And then we move on to other conditions for which the screening is slightly different, like for the critical cardiac conditions and for hearing. We have actually, the world has transformed. It has moved to more rarer and more expensive and newer sort of disorders that have been treated, such as the lysosomal storage disorders, the X-linked adrenal leukodystrophy, and the spinal muscular atrophy. The last two being actually treated using gene therapy. So when? So since there are three kinds of tests in newborn screening pertaining to the testing, the first is, of course, using blood, that is the dried blood spot. The ideal time to take a sample from the newborn is between the third and fifth day of life. Of course, that is going to be a challenge in many of the hospitals where there are early discharges. So as late as possible, as close to the discharge as possible. at least 24 hours of age. That should be the goal. And one could take a screening test a little later as well, but then you will probably uh, uh, lose the real idea of doing the screening if the baby becomes symptomatic. So the blood test and the critical congenital heart disease screening is actually done by the pulse oximetry. Ideal time is between 24 to 30 hours. For hearing is any time until the first month, the end of first month. So for the dry blood spot, this is the process. Basically, a dry blood spot, a drop of blood is taken from the heel of the baby and put it on the filter paper, which has a specific configuration. It is not very thin, not very thick, so it has a grade. And there are circles on the filter paper where a free flow drop of blood needs to drop, which will cover the size of the circle. So ideally, this 1 centimeter sort of circle would take 50 microliters of blood. So likewise, some laboratories ask for 3 spots, some ask for 5 spots. So this is a sample which comes to the lab, and then undergoing various testing. We'll talk about it. And what happens is the results is either a normal result, that means no further testing, or a positive result. So the positive newborn screening does not mean disease. It's just a step. So what it requires is a second tier testing. So wherever a second tier testing is not available, you please call the baby. Or you do a second tier testing. If that's also positive, then you recall the baby for the further testing. So coming to newborn screening for critical cardiac illnesses, all newborns who are more than 24 hours of age or near, I said, because sometimes there's an early discharge, so you may be able to do it after 12 hours, but it should be as late as possible. Because as you know about the ductus-dependent lesions, it may not show up that early after birth. So pulse oximetry reduces the early infant death rates from critical congenital heart defects by as much as 33%. So what do we do? I will tell you about the testing first. So a well baby in the nursery who's more than or equal to 24 hours of age, or if is nearing a discharge and less than 24, is an ideal candidate for screening. So there are 3 possibilities. If the saturation is less than 90% on the right hand or foot, then baby goes straight as a failed screen. If the saturation is less than 95 but more than 90 in the right hand, and there is a more than 3% difference in the saturations between the right hand and the foot, then it requires a repeat screen after an hour. But if the saturations are more than 95% and the difference is less than 3%, then the baby is fine. You can pass the screen. There's no further testing. So likewise, if the child continues to fail the testing in 2 further episodes, then the baby is deemed as a failed screen, leading to further consults with pediatric cardiologist and echocardiography and further confirmation of the diagnosis and so on. So newborn hearing screen. So this is something that's performed in my hospital for many years now, simply because the incidence is quite high overall, I would say. Then it's a very good screen, but let's just put it as it picks only the moderate and profound hearing loss babies. It may miss the milder degrees. The ideal time to do it is before the baby turns 30 days of age, or if it's nearing discharge, you can do it. If a failed test would require a repeat test after a gap of at least a few hours. It should not be done very quickly. So the process to do here is that is an autoacoustic emission test. So let's just presume this is a newborn. First, you can categorize whether there are any risk factors for this baby, which means the baby is otherwise low risk, healthy baby, or there are some risk factors. So all the babies undergo the OAE test. The ideal time, like I said, should be less than 30 days or just before a discharge. So baby would either pass the test, which means that's the end of screening, baby is fine, or the baby does not pass the test, which means baby needs to be referred. So all these referred babies, whether they come from the high risk category or low risk, they are subjected to further tests like the ABR. And then it takes some time. Within 3 months, this needs to be done and then referred to audio otologic center for management. All of these babies, if they are confirmed ultimately to have profound hearing loss, then they can be treated using cochlear implants. So coming to our core in blood-based newborn screening, congenital hypothyroidism being the prototype. So we are actually going from treatment to prevention to newborn screening. So congenital hypothyroidism is basically screened all over the world using one of the two methods. The TSH being the more used method. More than 90% of the labs are using the TSH method. But there are some labs that use the T4 method as well. So every laboratory has their own cutoffs, usual cutoff being 20 milliunits per liter. So once a baby is screened positive, like I told you, the algorithm, the second tier test on the same filter paper sample using another spot, if that also fails, then you call the baby and do a serum test. So unless and until these confirmatory tests show a TSH which is higher than the normal range for that age of the baby, one would not be diagnosing them or confirming them to have congenital hypothyroidism. So further tests required to confirm congenital hypothyroidism include imaging, the ultrasound and scintigraphy. It should be done in all babies who are biochemically confirmed. Then scintigraphy can be done up to 7 days after start of the therapy as well. Physical exam is required for all babies with high TSH, and especially because there might be few malformations here and there are certain syndromic diagnoses as well. Just for example, they could be Down syndrome, where congenital hypothyroidism is very common, up to 15%. So treatment of congenital hypothyroidism should be initiated as soon as possible, no later than 2 weeks, because it is time that is of essence. If you do not start treatment, baby loses IQ points by the day. So initial treatment of is with thyroxine, 10 to 15 micrograms per kg per day. In this hormogenetic types of congenital hypothyroidism, treatment can be stopped for 4 weeks when the baby is 3 years old, just to reassess whether it was a transient congenital hypothyroidism or permanent. So this is all left to the specialist, the endocrinologist who do it. Then this is another algorithm in the laboratories where the various cutoffs are used and what is the confirmation. Like I said, follow-ups require at least 36 months to be able to confirm whether it is a transient or a permanent congenital hypothyroidism. Coming to congenital adrenal hyperplasia. So this is another fairly common amongst the rare disorders, a fairly common disorder which is genetic, unlike congenital hypothyroidism, which may not have any genetic basis. So this is an autosomal recessively inherited condition with a prevalence of like 1 in 10 to 15,000. It can be classified as classic or simple virilizing CAH. It's the classic one, which is life-threatening, and it may also be associated with ambiguity of the genitalia, etc. So the test that is used for screening of CAH is the 17-hydroxyprogesterone levels, and the cutoffs are used by each lab. They decide the cutoff. In our laboratory, we use a cutoff of 60 for preterms and 30 nanomoles per liter for terms. And really speaking, there is a lot of difference. Whenever these borderline cases come to us, the repeat assay on a sample of DBS actually turns out to be normal. So like you know, a newborn period is really a stressful period for any newborn. So sometimes it's the stress that pushes up the levels, and when you repeat it, it becomes normal. So false positive tests are fairly common in this condition. So it must be confirmed before labeling the diagnosis. So once the baby comes for a confirmation, we must do serum biochemistry, which is 17-hydroxyprogesterone, the electrolytes, the cortisol, and also the corticotropin stimulation. So in the stimulation test, more often the diagnostic would be a 17-hydroxyprogesterone elevation from the baseline to more than 1,000. But literally speaking, the results go even beyond that. So treatment should be initiated after testing and before the results are available, just to prevent the classic crisis kind of situation. It's very easy. They are basically oral medications with hydrocortisone and fludrocortisone. And if there is any salt loss, then it has to be supplemented. And the families need to be guided regarding the stressful periods as well. So G6PD is quite common in our parts of the world. As you can see in the map, it's the red is the highest in frequency, and India falls in the red zone. So we have personal experience of diagnosing this G6PD in newborn screening, and the incidence is like 1 in 100 or something like that. So the test that is done, so G6PD deficiency gives rise to symptoms such as neonatal hyperbilirubinemia, which can be really nasty. It can lead to kernicterus if it is not treated early enough. And of course, there could be chronic hemolytic anemia as well. And later in life, there can be triggers because of some drugs or some toxic agents that the baby may encounter. So there has to be a list of drugs that given to the family to avoid. And most of them, the common ones are antimalarials and, of course, use of beans. So all screen positive babies need a confirmation by a quantitative G6PD enzyme test in the whole blood, not the DBS. And there's no particular treatment except for avoidance. Biotinidase is I would say, one of the best metabolic disorders to screen and to start treatment because it has the most fruitful results. Biotinidase deficiency, it is a genetic autosomal recessive inborn error of metabolism leading to shortage of the vitamin biotin. Biotin is an essential cofactor. It is used by 4 human carboxylases, and that's why it is really important. And why the biotinidase enzyme leads to biotin deficiency is because of this defect in the recycling of the biotin. The biocytin, which is the bound form of biotin, it has to get cleaved in order to release the free biotin for reuse. So if the biotinidase deficiency is not there, then the free biotin is not released, and hence there will be deficiency of biotin. Treatment is simply giving biotin. So how do we diagnose these children? The newborn screening is carried out by the dried blood spot, and there is a cutoff for all laboratories have their own cutoffs. But once the screening is failed, which means the baby does not pass the cutoff, then there ought to be a confirmation by quantitative enzyme assay in the serum or plasma, not dried blood spot. So a profound biotinidase deficiency is diagnosed when the activity level of the enzyme is less than 10%, and it can be little more than that, but then it becomes partial biotinidase deficiency. Treatment of any kind of biotinidase deficiency is supplementation of biotin, starting from as low as 5 milligram a day to up to 20 milligram a day. One small aspect is the avoidance of raw egg, which contains avidin, which prevents the absorption of biotin. Galactosemia. So galactosemia is a condition, inherited autosomal recessive genetic condition, which is brought about by any of the defects in the Lilloy pathway, and thus there are 4 or 5 enzymes that are involved. So the classic galactosemia is, of course, due to the deficiency of the transferase enzyme, galactose 1-phosphate So how do we do newborn screening? Well, on a dried blood spot, one could do one of the many things or a combination of things. The most common being estimation of this metabolite, the galactose, the galactose, not the enzyme, galactose. So if galactose is elevated, then you can take the further steps. But some laboratories also do galactose 1 phosphate. Some laboratories do GALT enzyme by a screening test called Beutler. And of course, sometimes there's quantitative. And confirmation is, of course, by assaying the individual enzyme, any of the 4, or genetic testing. So these are the differentials for a child who has a screen positive for galactosemia. The galactose, elevated galactose could really be either due to the classic galactosemia, or it could be the type 2 galactosemia, which is the galactokinase deficiency, or it could be any other conditions, one of the rare ones being citrate. So what do we do? Whenever there is a high total galactose, one of course repeats it in the lab and side by side does the GALT enzyme. If they are normal, then no further tests. And if they are raised, then it triggers other enzymes, because supposing it's the raised galactose, but GALT enzyme is normal, then you do further test. But if the GALT enzyme itself is deficient, then you have a diagnosis of galactosemia as well. So management of galactosemia, which is GALT deficiency, of course, is to completely avoid the lactose or galactose containing milk. So this is one condition where breast milk is absolutely contraindicated. It's one of the rare conditions. None of the other conditions, I would say, can you say that there is an absolute contraindication. Even for other metabolic conditions like PKU, one would tend to give a little bit of mother's milk. But here, it should be completely avoided. So in galactokinase, of course, again, the real treatment is to avoid the lactose and galactose. But looking into the morbidities, usually galactokinase deficiency does not lead to the systemic manifestations or any kind of liver failure like is evident for the transferase deficiency. What it leads to is cataracts. So in order to avoid cataract, one could continue to have these lactose-free diet. Cystic fibrosis is becoming a common condition in India. Well, when I say common, it is within the rare group, not as such common. But it is a condition for which newborn screening has been around in the world for more than 40 years. So it started in the early 80s. And that's how because it's very common in the Caucasian population, with the incidence being 1 in 2,500. We have done some recent studies of carrier screening, and we found that there is a high carrier frequency of this condition, but nobody has done newborn screening character, so we really don't know whether it is really common. This is the map of the world with cystic fibrosis in it. India figures somewhere here, which is like in the lesser frequencies. So cystic fibrosis is again a multi-system, very debilitating and burdensome disorder with lungs, the liver, the gut, and other areas being involved. So newborn screening is done all over the world using the immunoreactive trypsinogen. That's the #1 thing on dried blood spot. So trypsinogen is an inactive proenzyme of the pancreatic enzyme trypsin, which is released into the circulation from injured or inflamed pancreas. So these concentrations of IRT, they are elevated in the absence of the cystic fibrosis CFTR, the transport regulator, and particularly in neonates. So if it is a good screening test, but it's not a very specific test or even a sensitive test for cystic fibrosis. That's why there are more tiers involved. So once the IRT is positive, one could either go for another IRT. So that approach is IRT, or one could go for IRT DNA screening. But here again, there is a catch. This is really meant for the Caucasian population, where more than 70% of the mutation is actually the Delta 508. So this does not hold true for countries like India, where the incidence of Delta 508 is just about 25% or even less. So if we were to incorporate this screening approach, then it will have to be the whole gene sequencing rather than a mutation analysis like the targeted one. So cystic fibrosis is another disorder where one needs to become aware now, because this is also a treatable disorder. So there again, there are lots of protocols and flow charts in order to diagnose these children. The first test that needs to be done once the baby has a positive screen, which means raised IRT, then a sweat chloride measurement is required with various levels. There are various steps that needs to be followed. But just to remember that level of 60 or above of the chloride in the sweat is diagnostic of cystic fibrosis. So, and a sweat chloride level of less than 29 is fine, baby is fine. But somewhere in between, there have been lots of classifications like the cystic CFTR-related metabolic syndrome or cystic fibrosis screen positive, inconclusive diagnosis, meaning that these children cannot be straight away discharged. One should just keep them under the follow-up and until at least 6 months of age to have a clearer answer as to whether they have any kind of cystic fibrosis or not. Of course, genetic testing is one of the ways to clear the doubts. So these are just protocols for sweat chloride testing and with false positives and false negatives. So the standard therapy for cystic fibrosis involves the enzyme replacement therapy for all the pancreatic enzymes, and to treat the GERD, give all the fat-soluble vitamins, take care of the lungs by pulmonary therapy, and prophylactic antibiotics. Of course, lung transplantation remains an option for individuals who have severe lung disease. But now there are new approved and very advanced treatments, such as the lumacaftor, tizacaftor, ivacaftor, or combination, which have led to improved this thing, but they're really, really expensive. Now, switching gears very quickly to other inborn errors of metabolism, where India has not really taken up, but I feel that this is the area where we should now venture into, because there is no dearth of such disorders in India, and there is really a role of newborn screening in picking them up in order to improve their outcomes. Because once a child undergoes some kind of insult, it's really difficult to bring it back, almost impossible. So that's why you have to catch these babies while they are asymptomatic, and that can happen only by newborn screening. So these are some disorders that I have put in the list because of the so many, about 30 odd disorders, because we really need to focus on these disorders at least. So phenylketonuria. Phenylketonuria is the classic PKU is by the deficiency of this enzyme, phenylalanine hydroxylase, which converts the phenylalanine into tyrosine, which then goes around and does its own metabolism. So children who have PAH have accumulated phenylalanine levels and go on to have progressive and chronic loss of intellectual skills. And this is very much amenable to treatment through dietary modification. So this is another chart of newborn screening, how to bring about. There are differentials for this because they may not be the PAH deficiency. They could be the non-PKU hyperphenylalanemia conditions, which are usually the neurotransmitters and the tetrahydrobiopterin synthetic and recycling effect. So the cutoffs are again decided by individual labs, and there are two units that are used very confusingly. So in our part of the world, we actually use the millimoles. So let's just focus here. So levels of, while any newborn will have a level less than 120, so the screen is positive, or it is triggered when the levels go beyond, well, 200. So 120 to 150 is written here. So treatment is by dietary modification, which includes two things. One is protein restriction, but it's not just that, because if you just restrict the protein, you will make the child catabolic, will not gain weight, will again trigger the catabolic, the bodies in the protein, endogenous protein will break down and further aggravate the problem. So protein restriction has to be supported with supplementation with a special diet, which will provide all the requirements of the other amino acids and their calories. But that particular diet is phenylalanine free. So that's the idea. So supplementation by special phenylalanine-free formula, which is now available in India for the last 10 years now. So that's why it is high time that we start newborn screening so that we are able to do some good to our children. So having said all that, so the proposed newborn screening for any integrated program should be start with the basics. We can start with as little as one disorder, congenital hypothyroidism, but a combination becomes more cost effective. And of course, one could expand the newborn screening once you are set by using the TMS, which will then add many more metabolic conditions. And every state or authority has to also screen for newborn hearing as well as the critical congenital heart diseases. So these are so many metabolic disorders which can be detected by the expanded method using the tandem mass spectrometry. And a majority of them are treatable and also very simply. If you take an example of carnitine, all you have to do is give carnitine and baby remains well. Otherwise, it's a life-threatening condition. So one needs to take care of some special situations as well, because what about the babies who are sick, who are preterm, very low birth weight in the NICU? What to do, how to interpret, do we do the tests or not? Perhaps another time. Then all those babies who are stillborns and who all those families who refuse to give the samples, what to do. Anyway, I'll leave you with these thoughts, and but just one point, that let's save lives by newborn screening. Thank you so much.
Thank you so much, ma'am. Uh, and now I would request Dr. Mahesh sir to start his presentation, and I would request everyone to put their question in the chat box. We would take all the question one by one at the end of Dr. Mahesh sir presentation. Thank you so much. Thank you, ma'am, once again.
Hi, I will share my screen first. So thank you, Dr. Sunita ma'am. You have made my job very easy and very comfortable. Thank you for offering me that comfort. I just, since ma'am has given the basic insight about the newborn screening in her best expert ways, so that the new members who are, or those who are interested into understanding of newborn screening in the today's era, probably will have the idea what is the current status of India as far as the newborn screening status is concerned, and what is the way forward. I want to make this session little bit light by sharing some of the case studies which are probably more relating to our Indian case scenario. As ma'am has said already, some of the conditions are very common in India. So we should not be blindly following the panels which are recommended by the by the expert bodies like ACMG, straightforward. Say, for example, as ma'am has said, G6PD is very common in India. So G6PD should be one of the screening tests to be included in every Indian screening program, right? So according to my experience also, when I have been through the testing the TMS, GCMS, these basic conditions, enzyme studies, then I came across the finding that organic acidemia are very common in India. I don't know why, but the commonest one I have found is methylmalonic acidemia. So, and fortunately, this is included into the primary targets of RUSP, Recommended Uniform Screening Panel. Same is the case with glutaric acidemia type 1, propionic acidemia. This organic acidemia, I don't know, probably we are, the Indian genetic pool is having these organic acidemias, genetic issues, more as compared to the other parts of the world. So I think we should go with our own customized screening panels. And taking this point forward, I will just share some of the case studies very rapidly. I hope everybody will go through the case study and share their opinion or diagnosis. Okay, they can have an opportunity to write their diagnosis if they found it suspected for any particular condition, particularly IEM. Okay, so I'm sharing one case here. So case one is full-term normal delivery. Baby cried immediately after birth and uneventful. Day three, baby had feeding intolerance, failure to thrive, vomiting, lethargy. Serious. Then day six, she aggravated. Day nine, baby eventually needed NICU admission because of irregular respiration, respiratory failure, put on ventilation, and because of seizure episodes, she put on anti-epileptic drugs with some cyclic excessive movements. Of course, those are seizure movements. And one finding they found is fruity odor of urine and semen. And the sepsis screen was negative. They have done brain MRI. They found abnormal signal intensity in the brainstem especially and the basal ganglia. Fine. And these are the findings. You can see the MRI findings involving the basal ganglia and the base of the brain. And in MRS, this is one of the wonderful platform. A radiologist it's a blessing if you have a good radiologist in a metabolic workup setting like ma'am has in Sir Gangaram Hospital. If radiologists do send even some very classical radio pictures, here I have found one classical picture in the at 1 minute. You just figure it out later. I will move forward the screen. And this amino acid profile showed the branch chain amino acids elevated. And the urine organic acid showed the alpha keto acids. So any idea? They can type their diagnosis. Yeah, it is actually MSUD, correct. So I would like to tell you this MSUD being very classical and presentation is usually in the early phase of the early neonatal phase. And that's the reason we probably have precipitation of this intoxication effect disorder, specific amino acidopathy. And the classical of this diagnostic picture of MSUD is that the leucine is far way elevated. Valine, I have seen many MSUD condition wherein valine is very normal, but the allo-isoleucine is pathognomonic of MSUD. So if you have allo-isoleucine, this is definitely going in favor of MSUD. And you might be knowing, I will just give you some brief about the chromatographic technique we use in LCMS. So it's a 2-minute run of LCMS, wherein whatever leucine we measure, it's a measure of actually leucine plus isoleucine plus hydroxyproline. So there is one benign condition called hydroxyprolinuria. Okay, so this is benign condition actually. It doesn't decompensate to the extent of MSUD. So if we have to confirm this condition through separation of these individual amino acid, leucine, isoleucine, and in fact, these MSUD, some of the MSUD cases have deficiency of valine. So we got to check because leucine is the only ketogenic amino acid and harmful metabolite which need to be monitored in MSUD case. So these are the insight. So that's the reason ACMG has also advocated plasma amino acid as the confirmatory testing. And of course, the genetic testing would further confirm the cases. So this is one of the ACMG confirmatory algorithm for any elevated leucine level. So you have to go for the amino acids and urine organic acids for confirmation of any case with doubtful leucine levels, especially if it is above 350 millimole per liter. Consider whenever I'm telling you figure, it is most of the time, as ma'am has said, it is always followed in millimole per liter. Fine. So this is first case. Moving to the second case. Just guess. Consanguineous parents, normal delivery, birth weight 2.9, breastfeeding adequate. Day 21, baby had diarrhea and convulsion, poor feeding, hypotonic with depressed reflexes, respiratory distress, septic screen negative, ammonia is high, right? Electrolytes and lactates were normal. I have mentioned lactate in milligram per dl, actually, which is equivalent to around 2.5 millimole per liter. Okay, fine. So lactate is normal. Further findings, metabolic acidosis, anion gap elevated, serum lactate, I told you, later on elevated, CSF lactate also elevated, LFT normal. Treatment, this critical case is salvage to some extent with IV fluids and glucose, soda bicarb to manage the acidosis. And the acyl carnitine profile was sent and revealed C3 carnitine elevated. And urine organic acid showed methylmalonic acid, methyl citric acid, and propionyl glycine elevated. Any guesses? Yeah. So it's very straightforward case of methylmalonic acidemia, right? So why it is not propionic acidemia? Anybody? This genetic workup is also done and it is also found confirmatory. Okay, so this is a case of methylmalonic acidemia. So why it is not propionic acidemia? It's very simple. I'm telling you, whenever we were discussing about acyl carnitine or TMS profile, okay, what is the logic behind formation of any particular carnitine? Say, for example, here in propionic acidemia, propional carnitine is elevated. Why? Because this propionic acid is one of the unmeasured anion. There is a high anion gap, right? So propionic acid is elevated because of propional-CoA carboxylase deficiency. So this propionic acid, the body wants to get rid of. So it is either hydroxylated to 3-hydroxypropionic acid or converted into a non-toxic metabolite like methyl citric acid. So usually citric acid is prepared with the first phase of Krebs cycle. You know the first phase like oxaloacetic acid plus acetyl-CoA forms citric acid. So here acetic acid instead of acetyl-CoA, propionyl-CoA is joined. So it has one more methyl group. That's why methyl citric acid is elevated. So methyl citric acid is one of the, I would say, follow-up marker or a prognostic marker for propionic acidemia or methylmalonic acidemia deterioration. Okay, one thing. Secondly, this propionic acid is converted into 3-hydroxypropionic acid, which is phase 1 biotransformation reaction. Hydroxylation is the commonest phase 1 biotransformation. And third thing is glycine conjugation. This is phase 2 biotransformation reaction. So glycine conjugation forms propionyl glycine. And fourth thing is propionyl carnitine. So carnisure, if it is given, it is life-saving for that baby because this propionic acid is conjugated and get excreted because propionic acid as such cannot be excreted. So all these protective mechanisms of glycine conjugation, carnitine conjugation, hydroxylation, this is a picture or I would say fingerprint of that particular disorder, methylmalonic acidemia. So difference between methylmalonic acidemia and propionic acidemia is simple, straightforward. One single metabolite, that is methylmalonic acid, and the genetic workup, of course. So, and another thing you need to understand is any case of methylmalonic acidemia which is presenting early in the neonatal phase, they are usually mute deficiency. MUT. CBL A, B, C, D, they hardly present in the neonatal phase. They present later, little bit later in life. But mute deficiencies, they are most of the time, they are not their prognosis is not good. Okay, and their early presentation have got high morbidity rates. Okay, and all these organic acidemia, mind you, remember, we should have hyperammonemia. Most of the time they have hyperammonemia, elevated orotic acid in the urine sample, which mislead our thought process during diagnosis. Okay, and they usually have intoxication effects. Okay, this is the ACMG algorithm of elevated C3 level. There are multiple conditions which raises the propionyl carnitine elevation, propionic acidemia, methylmalonic acidemia, and so many other conditions. So herein, the diagnosis or differentiation between transcobalamin cofactor deficiencies need to be taken into account by measurement of homocysteine simultaneously, or in the second phase of screening. Okay, so this is the second condition, second case we have studied. This is methylmalonic acidemia. Okay, third case, you just extrapolate. 11-month-old FTND, male baby, birth weight 2.5, delayed development followed by neuroregression, NICU admission due to coma, history of episode of viral meningitis at 3 months of age. Remember, 3 months. Then acute episode of encephalopathy requiring ventilation, excessive cry, irritable at 5 months, seizure at 11 months of age. Ammonia is high. After carnitine, it came down. So after carnitine. And then MRI findings are showing multiple infarcts in brain and cerebral atrophy. Okay. Got it? The positive findings, you noted it down, right? So, sorry. So organic acid showed the glutamine elevated, orotic acid elevated, and low citrulline level. So it is OTC deficiency. So diagnosis, I typed it before the findings. So the confirmation of genetic studies also confirm the OTC deficiency. So this case being a male, okay, manifested for the OTC because this is X-linked recessive disorder, right? And there was a history of in the family itself with neuropsychiatric symptoms for the sibling, elder sibling, which is female actually, which was a carrier for this particular family. So most of the time the females are carriers, and if at all they are having partial OTC deficiency, and they usually present with neuropsychiatric symptoms, not profound hyperammonemia and classical encephalopathic features. Okay. This is the algorithm for urea cycle defects. So for diagnostic algorithm, any case with elevated ammonia has to be checked with pH and plasma amino acids, and check for citrulline and arginine. Okay, if citrulline is low, then there are two differentials, right? Those are OTC or arginosuccinate. Citrulline is low, so OTC or proximal urea cycle defects, like CPS1 or NAGS, correct? Okay, or if it is citrulline is high, then it is arginosuccinate synthase deficiency or arginosuccinate lyase deficiency. So these two, citrullinemia type 1 and 2, can be differentiated with arginosuccinic acid estimation also. So some of the labs, I don't know, but some of the labs are giving arginosuccinic acid also in the tandem mass spectrometry profile. So that helps us actually, whether it is citrullinemia type 1 or type 2 or arginosuccinic synthase or lyase deficiency. And only arginine elevation is very straightforward, that is arginase deficiency, right? Okay. Moving on to the next case. This is female full-term uneventful pregnancy, normal Apgar score presented at the age of 3 months with severe metabolic acidosis. Okay, electrolyte and lactate normal, ammonia is little bit high, documented hypoglycemia, similar episode 15 days back, precipitated by fever and cough. So similar episode precipitated because of fever and cough, and sweety feet odor during acute illness. Any cases? So is it hypoglycemia with organic acidemia, with ammonia? Yeah. So amino acid profile is normal, but acyl carnitine profile showed C5 elevated with low free carnitine. And organic acid analysis, as I told you, yeah, correct. Isovaleric acidemia, correct. So it is just like our typical organic acidemia case. So confirmation is also done by genetic workup, and it proved the status of IV. Okay, another case, a very interesting case. 1 year female, FT and hypotonia, large head. Remember, large head, delayed mild development, mental retardation. History of consanguineous marriage, paternal grandparents had second degree consanguinity. History of MR in the maternal grandparents. Okay, brain MRI, bilateral signal intensity, high signal intensity, but sparing some areas, sparing cerebellar area. Okay. And this is the finding. You can see the subcortical high intensity area, and cerebellum is not there in this section, but it is spared. Okay, and you have the one peak in MRS, which is significantly elevated. That is NAA. Anybody knows this metabolite? It is N-acetyl aspartic acid, and it is elevated in the urine organic acid analysis as well. So what could be the diagnosis? Correct. Canavan disease, N-acetyl aspartase deficiency, correct? Okay. So molecular confirmation was also done for this case in our lab with ASPA gene mutation analysis, right? Okay. Another case, which is 4-month-old, presented with seizures, vomiting, very common case actually. You can guess it. Ma'am has also covered this disorder. Seizures, vomiting, poor weight gain, loss of scalp hair, 1 month. Second child born to parent with third degree consanguineous marriage. The child was on breastfeed till 3 months, after which she started having episodes of seizures. Okay, each episode lasted for 3 to 5 minutes. Child put on phenobarb because of this. And the baby had frequent episodes of vomiting, continues to have acidotic spells, the seizures, and developmental delays. Okay, got it? Any guesses? You keep it in mind. Also, baby developed diffuse thinning of scalp hair with loss of hair. No family history of epilepsy or similar complaints. Elder sibling is normal. ABG usually showing metabolic acidosis. Acyl carnitine profile goes C5OH. Hydroxy isovaleryl carnitine. Any guesses now? Probably this case has become more clearer. Metabolic screen showed biotinidase deficiency, correct? And serum, which is confirmatory, showed the activity which is in 10th percentile, less than 10th percentile of the normal activity. So it is clear-cut case of a biotinidase deficiency, which improved a lot after biotin supplements. And as ma'am has said, is absolutely correct. Anybody can have this biotinidase deficiency, can have very good outcome, because biotin supplement is what is required actually. Okay, and mark improvement in baby's condition after supplements again further confirm the diagnosis. Okay, fine. So moving to the next case. This is very self-explanatory condition. Neonate with clitoromegaly, gonads not palpable, single urethral opening, fusion of labia, raised 17 OHP, uterus present in USG, and baby had some systemic manifestations, failure to thrive, severe dehydration, hyponatremia, hyperkalemia, compensated metabolic acidosis, normal karyotype, female karyotype, and put on fludrocortisone, right? This is clear-cut case of CAH, fine. And which is confirmed again with the genetic workup. Second case, I think the last case I'm having this. This is very interesting case. 4-year-old. You imagine newborn screening, it might be missed actually for some of the conditions, because these are not some of any of the normal metabolic condition. 4-year-old female, just guess out now. Admitted in our hospital recently, last year, we got this case. Hypoglycemia and lactic acidosis, severe lactic acidosis, severe documented hypoglycemia up to the level of 30, documented on 3 to 4 times almost. Okay. Convulsion was there at the time of precipitation of hypoglycemia, altered sensorium. Baby was completely mute, kind of. Okay. Prenatal, natal, and perinatal history was absolutely uneventful. Lab findings, glucose low, severe metabolic acidosis, ketones very high, glucose negative, normal MRI. And the baby responded immediately with a single infusion of glucose and correction of acidosis. Immediately responded. What could be the scenario? And now one more thing I would like to add in this case is the baby had, when they digged out the history, the baby had to 1 day back before the baby had a juice, ganne ka juice. What is that called? Sugarcane juice. Any idea now? Urine GCMS analysis showed lactic and ketosis, and GCMS analysis shows fructose, glycerol, and glycerol 3-phosphate. Now, any clues? Now it has become very simple and self-revealing, right? Now, YAP-BP1 gene. Now, any clues? Yeah. It is fructose 1,6-bisphosphatase deficiency. This is classical presentation. One of the classical case, I have narrated it here. We got so many cases from all parts of the India actually, wherein we found these classical features, and the parents were not able to figure it out. This particular presentation, they used to attribute this to something else, or probably resort to some babas and buas, probably. Okay. But fortunately, we found this case from one of the remote areas of South India. Okay, fine. And last case, this is also interesting case. Baby boy born to non-consanguineous marriage, uneventful antenatal perinatal history, discharge after newborn screening, NBS performed, and we found the total galactose level elevated, and we found the total galactose level very high. And we have done as a second tier testing, as ma'am has said, we have done GALT, and GALT has found very low, right? And sorry, it was normal. GALT was absolutely normal. So what we have left with is genetic workup. We have done clinical exome for the galactosemia, and we have found GALK1 gene. This is galactokinase, because we don't have the galactose 1-phosphate estimation. Otherwise, level of both are elevated in galactokinase deficiency, right? And that is how we have settled down this diagnosis. Okay. And as ma'am has said, the cataract is very common as compared to GALT, classical galactosemia, wherein systemic manifestations are too many. But here the only 2 to 5% cases of all galactosemias are having kinase deficiency. Okay, so restriction of lactose or galactose is proved very beneficial for the baby, and the baby had a normal growth later. Okay, this is all from my side. Okay, I hand over the mic to Krishna.
Yes, sir.
Thank you.
Thank you so much, sir. It was indeed very interactive and enlightening case studies that you have presented. I think we have answered all the questions which had come on chat box. We would wait for another couple of minutes. If anyone has any question, please type in. And Dr. Sunita ma'am and Dr. Mahesh sir would be happy to answer those. So we have one question, ma'am, from Dr. Nikhil. What should be the cutoff of serum ammonia level above which it has to be further evaluated?
Okay, thank you for the question. So when it comes to ammonia, we have to first check the age of the baby. So there are different normal levels for neonates, for infants, and for adults. So, and of course, we have to check whether the ammonia testing was done accurately, keeping in mind all the transport conditions and all that, because it's very, very common to have a technical errors in the estimation of ammonia. So it has to be sent, it has to be a free-flowing sample, it has to be sent on ice, and it has to be measured very quickly. So if there's any delay, if the sample is made to rest in room temperature, the ammonia levels go high. So the normal levels in a neonate are anything up to 110 for a healthy neonate. And for preterms and sick babies, we can allow up to 150. So one becomes concerned if the levels go higher than these levels in a neonate. For an infant, the levels are 80 and 100, like that. And of course, for more than 1 year or adult population, it is, some labs say 35, some labs say 55. So because there are two units again for the ammonia, so one is the micromole per liter and one is the milligram. So we usually use the micromoles. So for that, the levels above 55 are considered high. So does that answer the question?
I'm sure, ma'am. So we have the next question. Is there any way we may send DBS for MS where the patient is not able to afford testing?
That's not a medical question. That is directed to MedGenome.
Actually, it is based case to case basis. Okay, we do have we can support them as far as the criticality of saving of the baby is concerned. Definitely, high risk screening is what is resorted to in India. Okay, MS based, as ma'am has said, MS based is expanded screening, which we usually don't do in India, at least. But we can think of it. Okay.
So I can just put in a word that although I am in a private hospital, we do charge for everything, but there is no limit. So we very often we get samples or patients from government hospitals who are poor, and we do not charge them. So it is just case to case basis. Please do not hesitate in calling up or sending samples just because the patient or the family doesn't have money. Please go ahead and contact.
Next question we have, what is the incidence of these diseases discussed today in our country?
Okay, so I can give you a little idea about that. So basically, individual disorders are quite rare. If we just consider the list of newborn screening the disorders, the number one highest in prevalence is G6PD, which is close to 1%, I would say. The other is congenital hypothyroidism, which is more pertinent clinically because this needs treatment. If you miss it, you're going to have a child with intellectual disability. So the incidence varies from all parts of India. So as you know, in the Himalayan, because of the iodine deficiency, they're bound to be higher than the coastal areas, but nevertheless, it is quite high. in my hospital, we have calculated the prevalence of congenital hypothyroidism to be somewhere between 1 in 1100. So it's quite high. But when it comes to the inborn errors or the inherited disorders, they are not that high. Like the most common, like you can say, is the cystic fibrosis elsewhere. But in India, congenital renal hyperplasia could be said that the prevalence is somewhere between 1 in 10,000 to 1 in 15,000. That's also not very uncommon. But if you put together, because when you're doing a newborn screening, and if you're going to go with the expanded newborn screening, you are going to consider more than like 30 disorders. And collectively, you are going to pick one case in, let's say, 2,500 babies. So if you remove congenital hypothyroidism, just the newborns, just the IEMs. So collectively, they are not that uncommon. So one should go ahead and do newborn screening.
Yeah. I just want to add one thing is, as ma'am has said, 1 in 100 is the experience in G6PD, which may be more than this, only because we are reporting only severe cases of G6PD. If we try to include the partial deficiencies also, those could be very, very high. Another point is related with collective deficiency or collective IEMs. Okay, this most of the literature says is 1 is to 350, 1 is to 400, but I think it is more than this. It is definitely more than this, for sure.
Maybe it's South India because there's lots of consanguinity there, so you can find it.
Yeah, yeah.
Like PK is very common there. It's not that common in our part of the world.
Yeah.
Next question we have, if IRT is elevated, we usually straight away go for molecular testing. Any rule for sweat chloride if IRT positive or borderline? Sweat chloride test is not very easily available these days.
Yeah. So we are still struggling with the protocols in our country because number one, nobody does newborn screening. And in our country, it is really left to the, the families. If they opt for it, you get it done. It's not like a universal process. That's why the protocols are not uniform. In our hospital, of course, there is sweat chloride testing. We do sweat chloride before the confirmation by genetic testing. But you could go ahead because looking at the scenario, whichever is available, and probably not that expensive as well. So that's why one, as IRT mutation or IRT DNA algorithm could work for cystic fibrosis as well. But one has to bear in mind the intricacies of the genetic testing. So as you know, in MedGenome Lab, there are so many discrepant results because any variant gets reported and then as a VUS, variant of uncertain significance, and for the uninitiated who doesn't know the intricacy of genetic testing, they may just accept the diagnosis as is, and which could really be detrimental. So I would really advise that if you were to go for genetic testing, please take an advice of a clinical geneticist. So that would really solve your issue. And it's not hard to find a geneticist in India. Now there are lots of them.
Yeah. And as far as this question is concerned, ma'am, I just want to add IRT is not specific marker.
Yeah.
It is
Yeah.
specific only for the first 2 months.
Yeah.
And ma'am has in her slide, if you have carefully seen, she has shown some algorithms, different algorithms based on different guidelines actually. So what guideline, what algo we follow? If elevated IRT is there, we repeat IRT after 2 weeks. And if that IRT is also coming persistently high, go for the sweat chloride or the CFTR gene analysis. That
yeah. So IRT is really non-specific, and there are no specific levels as well. So many of the laboratories actually take the top 1% of the levels for the day. So it's not just a particular level, let's say 75 or 100 or 125. It's just, let's pick the highest level and then let's put it as a positive, go for the next level testing.
Yeah, thank you, ma'am. Please mention the unit of ammonia level. I think ma'am has answered in the first question. It was 55, if I remember it correctly. And so we'll move to the next one. Uh, Presumptive positive dried blood spot should be preserved for how long?
Well, all the dried blood spots are preserved. It's not a matter of just preserving the positive samples. So there is a mandate in many countries to store these samples because they are a source not just for the said disorder, but also for so many other tests. So in our lab also, we do store the samples at 4 degrees, for a long time, say to 21 years.
Correct, ma'am. Yeah, it is really, actually, Sunita ma'am has said the incorrect words. One experience I want to share with you is you have to store every positive sample at least. Why? Because the parents do save lots of money and lots of concerns in the next pregnancy. We can have the proband analysis. We can have the targeted mutation analysis in the prenatal phase in the during second pregnancy, and the job becomes very easy for a geneticist also to settle down the case, to counsel the parents accordingly, and to stop this repeated cascade of repeated baby with a similar IEM in the family itself. Yeah.
And so do we have any pan-India study for cutoffs for DBS, AA, and AC profile by TMS? Dr. Yasir has asked.
Let me answer first, then Dr. Hampi can take over. So we've had ICMR task force multi-center study for newborn screening for 2 disorders, the congenital hypothyroidism and CAH. So there were 5 centers that took part, and they screened for 100,000 babies. So there were some cutoffs, but they are not to be used because it is basically the lab has to build their own cutoffs. So that's what it is. And maybe Dr. Hampikin, with your experience.
Yeah. Actually, the cutoffs are actually subjective. As ma'am has said, we have to design the cutoff in such a way that we should not throw out false positive and false negatives. Those should be based on the percentiles, the incidence rate, and the confirmatory matrix, which you have performed simultaneously using either a reflex testing or a secondary testing. So that becomes a logic for you to design the custom or lab-based cutoffs. That's it.
Do we have any ongoing project for suspected patient? That's the next question. The next question, Dr. Seema is asking, do we have any ongoing project for the suspected patients?
Suspected patients, newborn screening is not for suspected patients. It's universal. It's for all babies who are born. Are you trying to ask about high risk screening, which is the term that we devised just because there's no universal newborn screening. So maybe you can contact me separately and I can answer.
Yeah.
I think ma'am has answered. Both have said that universal screening is a kind of they are suggesting. So next question is answered already. And next question for the ma'am regarding the PKU, frequency of screening, level to be maintained, name of the protein supplement.
It's for you, ma'am.
Ma'am, screen has hanged actually, I think network issue. Yeah.
Okay.
Yeah, ma'am, the question is for you.
Yeah, please.
Regarding the PKU frequency of screening, levels to be maintained, name of the protein supplement.
Yeah. So it's not screening anymore. Once you have diagnosed a baby with PKU, it is monitoring. So we have to regularly monitor the levels of the plasma phenylalanine. And initially, it is more frequent, like let's say every 3 days, 4 days, to weekly, to once in 2 weeks, to monthly. And then maybe one should continue monthly levels. And the levels that are maintained, there is a therapeutic range, which is like between 300 to 600 for older children, but less than between 2 to 400 for younger babies. So there are guidelines and one could adhere to them. basically it's the diet only that is going to make the difference. But there is a subset of babies who have PAH deficiency who may be responsive to the tetrahydrobiopterin or the Kuvan, which is now available in India. It's an oral medicine, and only about 30% of the babies may show some response to that, which means that you can relax the diet if the baby is responsive to that. And there was another question there, the diet. So there are two companies in India who are now producing the special dietary products. The Pristine is quite established now, Pristine Organics. They have their products according to the disorder. So you have to give them the disorder like PKU1, if it is meant for babies under 3 years who have PKU, or GA1 diet is meant for babies who have glutaric acidemia. So each disorder is different. So each product is really, really specific. So you cannot interchange. Aaj PKU nahi mil raha, chalo GA1 le lete. No, it has to be PKU1. Okay. And the other company is the SP Enterprises. So it's relatively new, but they also have good products. Apart from that, their well-established international products are sometimes available. So they are from Nutricia, they are from Abbott, and they are from even Nestle, Comida. There are many companies that are making.
Thank you, ma'am. Next question is for sir. NBS result take how much time?
NBS, which test you want to perform is most of the labs usually give results within 48 hours, 24 to 48 hours. So it's very simple kind of test. We have to just punch the sample and process the sample for either ELISAs or the tandem mass spectrometry, and you get the results within 48 hours. And if confirmation is required, then probably additional 24 hours will be spent for secondary testing.
Thank you, sir. We had many questions regarding the sharing the PPT. So I would tell everyone that we would be posting this video on YouTube. So we would not be able to share the PPTs, but yes, the content will be available online so that they can refer whenever they want. Okay. Next one, sir. What are the red flags for indicating NBS?
Can I answer this?
Yes, ma'am, please.
Okay. So with MPS, you mean mucopolysaccharidosis, right? I think I should switch it on. So basically, the red flags are taught in our pediatric training, and they are basically the children who have certain distinctive facial features, which is like coarse faces. They have rough kind of skin. They have contractures. They are short. They can have frequent URIs. They can have respiratory problems like pertaining to the heart. They could have joint contractures. So there are they call corneal clouding. They can have progressive intellectual disability. So they are, but because of the distinctive facial features and the combination, you can actually recognize them clinically. And however, it's a complete topic altogether. We can have another webinar on it.
Yeah, anything beyond sepsis is a red flag.
Well, with sepsis also, because they do have recurrent infections.
Sure.
We have last 3 questions, in fact, 2 questions. One is the comment from Dr. Simasa, who had asked for that universal testing project. She said she will get in touch with you, and she was asking for confirmatory testing and treatment. So that is done. Last 2 questions we have. Does the test detect spinal muscular atrophy, SMA?
So there is yes, there is newborn screening for SMA, but you have to devise a separate test for that. It will not get done automatically. So
see, I just want to add this. SMN is the last addition into the RUSP recently, because 2018 they have suggested the RUSP. Later on, Pompe, MPS1, then SCID, then this XALD, they are all added. Then MPS2, MPS1 to XLD. Then this is also a recent addition. So it requires a separate test altogether, so which is not routinely been done. So you have to, it cannot
basically a
be
molecular test. It has to be
it's a
like a
molecular
deletion test. Yeah, can be done on DBS.
Yeah.
Okay, last question we have. Till how many years DBS can be used for DNA extraction to be done in case a baby is expired?
So it depends on how well the sample has been stored. So while the viability of the blood sample is less if it is stored at room temperature, although even it's probably good for months. But then if you want to increase the viability, then it has to be stored under 4 degrees Celsius. So that is years then.
Yeah. The only constraint is moisture. If you will
Yeah.
take care of the moisture, probably that sample will be a blessing for that family.
Yeah.
Sure. I think the questions are over. I would say, ma'am and sir, this was one of the most engaging webinar we had. We had more than 50 questions or comments. So that itself speaks about the kind of webinar we had. There were a lot of participants who were thankful for such a presentation for both you, ma'am and sir. And once again, thank you so much for your time and
Thank
helping
you
us
so much,
understand.
Jerome. Thank you, Dr. Mahesh. And thank
Thank
you,
you, ma'am.
participants, for making this and giving me the opportunity. Thank you so much.
Thank you, ma'am.
Thank you. Thank you very much.
Thank you,
Thank
sir.
you.
Bye. Good night, ma'am. Bye, sir.
Sure.
Good night.